Good morning, everyone. Welcome to Pediatric Drive Round. If you are anywhere near the Tanglewood Conference, please join us in person in the Mill Mountain Conference Room. And as always, we thank you for joining us online. Today's speaker is Dr. Allison Moran, one of our outgoing third-year residents. Dr. Allison Moran grew up in New Jersey, climbing trees and playing outside. She received her undergraduate degree in biology from the University of Maryland in College Park. She then migrated to Las Vegas, Nevada for medical school. And she found a passion for pediatrics and graduated from climbing trees and rocks. I think she just got to bigger rocks. She came to Carilion 3 years ago and currently serves as one of our third-year chief residents. She will be continuing on in this role as a fourth-year chief next year. Please join me in welcoming Dr. Allison Moran.
Okay, good morning. So we're going to talk about kind of RSV updates, new discoveries, and new prevention modalities that have come about because of those. I have no disclosures. That being said, a lot of the data in here was funded by the companies that have produced new technology, AstraZeneca, Sanofi, and Pfizer. So do with that what you will. And if they're listening, I'm open to disclosures. So in the beginning here, we're going to talk about RSV and kind of refresh our knowledge of what we already know. We're going to talk about the impact on our patients and on the medical system. And we're going to talk about the new prevention modalities. So we'll start with a quick case. So it's November, and you have a 5-month-old that comes into your clinic. Mom says 4 days of runny nose congestion, cough, and a low-grade fever. All of a sudden, raspy breathing today. On your exam, they're well hydrated. There's crackles throughout their lung exam. They're not breathing hard. There's some coarse breath sounds and a few wheezes here and there. What do y'all think this is?
RSV.
RSV. Bronchiolitis, it sounds like, because they've got those lung findings, so definitely a lower respiratory tract infection. RSV for sure is our major cause of bronchiolitis in this age group. So we've got our structure here on the left, and just histology showing the syncytial cells that RSV is named after. So RSV, just a reminder, is a enveloped, negative sense, single-strand RNA virus. It's in the family orthopneumovirus in the genus Pneumoviridae. The other notable family in that genus is the Metapneumoviridae. So human metapneumovirus, they're pretty closely related. Our highlighted proteins here, the G protein for attachment to host cells, and the F protein or fusion protein for fusion. These are kind of the major virulence factors that have been targeted for treatment or prevention. And then it has some other proteins, some that affect the immune system, some that are structural. And it's a fairly small genome, only about 15,000 kilobase pairs. Pretty much humans are the only hosts of the human strain that we commonly encounter. There's a bovine strain, and it was originally discovered in chimpanzees. So usually starts as a URI, as you all know. About a third of cases go on to become a lower respiratory tract infection. It can be bronchiolitis, can be croup, can be pneumonia. Replication of the virus is most efficient in the terminal bronchioles, thus the bronchiolitis. You get sloughing of the ciliary epithelium, you get big mucus buildup, you get vascular permeability and invasion of immune cells, submucosal edema. All of these things can lead to the mucus plugging, some of the wheezing that we hear, patchy atelectasis. You don't need an x-ray to diagnose it, of course, and this x-ray shows a severe case. That right upper lobe atelectasis is pretty common. You can see the perihilar cupping, and you can kind of see patchy atelectasis throughout, some hyperinflation. And it's obviously severe because this kid is intubated, and I'm sure in the PICU. So infectivity or transmission, Incubation period is about 2 to 8 days. Viral shedding is usually around 8 days until symptoms start to go away, but in immunocompromised individuals can last for much longer. It is spread by droplet, so when we're seeing those kids and examining those kids up close, you want to be wearing a mask and goggles, but also by contact. This one study showed that it lives about 6 hours on surfaces, 90 minutes on gloves, 20 minutes on skin. So you're going to want to wash your hands and wear gloves because this is an epidemic and we want to limit the spread. So RSV is the leading cause of acute respiratory tract infection in children up to 5 years old. And this was taken out of Peds in review. Almost all children have had RSV by the time that they're 2 years old. There's an old study from Houston in the 90s that showed 99% pretty ubiquitous antibody production by the time kids are 2. The first infection is almost always symptomatic and has the highest risk of being a severe infection, with frequent reinfections that become less severe, and about a 30 to 75% reinfection rate under 2. So see it all the time. There's 2 antigenic subtypes. There's some debate over if the A subtype causes more severe disease over the B, but not all studies show that, so do with that what you will. They do cross-circulate throughout the season without much cross-immunogenicity, so you can get reinfections in the same season. And it seems like the innate immunity that we produce, at least for the first infection, doesn't last very long, like 2.5 months. So it's probably about the rate that y'all have seen people coming back with another RSV infection. So talking a little bit about the burden. So these numbers come from the CDC. In the US, about 2.1 million outpatient visits every year for RSV. 58 to 80,000 hospitalizations. Another way to think about that is that about 3% of every birth cohort will be hospitalized for RSV, and 100 to 300 deaths in the US, which is very low. 99% of the deaths due to RSV worldwide occurs outside of the US, in developing countries. Outside of just the medical care for RSV itself, you get the secondary bacterial pneumonia, secondary ear infections, and then there's an incompletely understood correlation between early RSV and like a wheezing asthma phenotype down the road that's treated the same as typical asthma, but tends to be refractory to our treatments. Not sure if there's some genetic predisposition or damage from the virus or bacterial superinfection that leads to things like this. This study in 2017 was funded by AstraZeneca, like I said, looking at the chronological age of hospitalization for children preterm and term in the US. It's different studies and it's broken down by different studies and different age groups. But the key takeaway here is that 6 months and under, if you total up all these, you get around a 70-75% rate of hospitalization. So our kids that are at risk are really those year and under, but especially the 6 months and under. So those are the children that have been targeted for new prevention. You guys are familiar with the seasonality. The CDC defines the seasonality in the continental United States as November to March. And you can see here our first solid blue line, 2017 to 2018, pretty typical season. 2018 to 19 is our long dashed blue line, typical season. And then we get to 2019 to 2020, which y'all know, rumblings of the pandemic started kind of January, February. By March, everything had shut down. So I do think we see a steep drop off maybe when people were starting to be more careful and stay inside. And then that line, that small dash blue line, becomes the long dash dot black line, where we didn't see any RSV for just about a whole year until things started opening back up. And then we had that crazy 2021, 2022, kind of 2020, it just didn't even follow the pattern that we normally see, right? In June, we peaked in July, August, September, October, November, December. It was everywhere. And everybody wondered, what is RSV going to look like going forward? Then we've got our 2020 to 2023, peaked early and peaked strong, but heading back toward what we were accustomed to. And here's Virginia. This has 2022 to 2023, 2023 to 2024. This is from the National Respiratory and Enteric Virus Surveillance System. The CDC and these folks, they always have up-to-date information about when tests are positive, and give you information about seasonality. So this year, this goes up to a couple weeks ago, we started peaking kind of September, October, coming down in January, a little bit more like a normal season. So it looks like we might be coming back to what we know. Seasonality is different outside of the contiguous United States. Tropical climates don't tend to have the peaks that we see here. And Alaska tends to have kind of a longer season of RSV. So the treatment, y'all know, is supportive, right? Hydration, oxygen. The pharmacologic interventions we have don't really show much effect. So really prevention is the thing we harp on for any upper respiratory virus, especially RSV for those babies under 6. Doing the best you can to avoid crowds and avoid daycare. It makes you wonder about maternity and paternity practices in the United States. And if these are the recommendations we're handing out, but that's a talk for another day. All right, I like this picture because that baby is so psyched to get that shot, and that woman is barely holding him down, so she must be really, really good at it. So we have to wonder why we didn't have a viable vaccine option until 2023. Does anybody know when RSV was identified?
In the late 60s?
Yeah, so late 50s. It was identified, first called chimpanzee coryza agent, and then quickly found titers in almost all school-age children, renamed to respiratory syncytial virus. They first attempted a vaccine in the early 60s, active immunity for children. This resulted in, it was not efficacious, and in some children had a really strong Th2 immune response that led to really severe lung disease and even death in some. So that kind of halted, as you might expect, attempts at a vaccine for a long time. That would put a lot of people off. So this is from PATH, which is an NGO out of Seattle. The WHO website links to this, and they're just keeping track of what's available for RSV. The things that we're going to focus on today, y'all know about palivizumab. That's been around for a while. Nirsevimab is the new immunoglobulin that's been approved recently, as well as the maternal Pfizer RSV vaccine. It's interesting just to check on here that there's some, they're going for active immunity again down the pipeline for pediatrics. So it'll just be interesting to see what comes about in the next few years. So what changed recently? About 7 to 8 years ago, they identified that there's this, on the left, the more colorful, shorter guy, is our stable pre-fusion protein on the RSV virus that it turns out has epitopes with much stronger neutralizing potential. You can see that palivizumab is targeting the 2 epitope that is present on both, but usually hits the post-fusion, and the pre-fusion is really where the virus attaches, and a lot of its virulence comes from. So nirsevimab is targeting, as we know, the most neutralizing epitope that we found, that 0 epitope. So this is a big thing that happened and kind of led to a lot of what we're seeing today. Oh, and then something very interesting. So this study, they looked at sequences of RSV way back to when it was discovered in 1956. Most of it came from 2015 to 2021, but thousands and thousands of strains of RSV, and they found it's a really highly genetically conserved virus. So even if there is an amino acid shift, this nirsevimab, it still binds with great neutralizing potential, It's like 99% conserved. There was a like less than 1% rate in the B strain of a amino acid polymorphism that did decrease efficacy, but it'll just be interesting to see like how long this continues to be helpful, or if RSV finds a way around it. Monoclonal antibody therapy, I just bring this up to remind you of the shape of the antibodies, right? You got 2 heavy chains and 2 light chains, the antigenic portion on the top of the Ys and the FC portion on the bottom of the Y, binding and preventing fusion of the RSV virus to our host cells. So we'll just refresh on palivizumab. What we already know and have been using for a while. It was approved in 1998. It was studied and approved in this really narrow population, right? Pretermers, 29 weeks, chronic lung disease of prematurity, and those with hemodynamically significant acyanotic heart disease and or moderate to severe pulmonary hypertension. So not a lot of kiddos are eligible to receive palivizumab, but the majority of kids we see getting hospitalized are really like the healthy term kids, less than 6 months old. So there's been a big gap there. Some of the other high-risk things that weren't directly studied when they put out palivizumab are things like severe cystic fibrosis or cystic fibrosis with malnutrition, kids with Down syndrome. You consider some of these things on a case-by-case basis, neuromuscular disorders. And then Alaska Natives or American Indians tend to live far from medical care, and therefore can be at risk for severe disease. I bring up all of those things because those are going to be our high-risk factors that are going to qualify a patient for a second dose of nirsevimab. So nirsevimab, a few differences. One thing that's really cool is that they modified 3 amino acids in the FC portion that allows it to bind to the neonatal FC receptors and greatly increase the lifespan in the serum to 5 months or so. So that's what they studied to see kind of rates of preventing severe lower respiratory tract disease and hospitalization. Titers remain high at a year out, but they didn't see a big difference in rates of lower respiratory tract disease. And that's why they're recommending a second dose. So this is approved for all infants less than 8 months old entering their first season and certain infants entering their second season that we talked about. It equates, it doesn't sound like all babies, but I'll show you with a graphic that makes it a little bit easier to see when the babies would get their injections, and it's all babies. This was FDA approved in July, and what's really cool and different from palivizumab is that in August it received approval by the Advisory Committee on Immunization Practices of the CDC, and they approved it to be treated like a vaccine and approved it to be eligible for the Vaccines for Children program, which provides vaccines to those who otherwise couldn't afford them. So they're really trying to increase access to this, which is fantastic. It was evaluated for safety and it was shown to be pretty safe. There's localized reactions and some rashes, mild to moderate, in less than 1% of patients. So nothing big. Of course, it carries that risk with any other human immunoglobulin of anaphylaxis. Okay, here's that picture. So the letters at the bottom here in these columns are just the first letters of the month. This pink part on the right is our RSV season. So as you can see in the top here, these are babies born in the RSV season. They're going to be getting their dose during the season. The CDC defined the season as November to March. And then babies who just missed the season, born April, May, June, etc., are going to be 8 months old or younger at the beginning of the season. You can treat them kind of pre-season October, treat them in the beginning in November. So as you can see, everyone in the birth cohort at some point or another will be eligible for this vaccine. When do you give it? CDC is recommending within the first week of life for those born during the season. They're recommending it can be given at discharge from the hospital or at that first pediatrician visit. And then, of course, just in October and November for those other kiddos that are born outside the season. It was evaluated concomitantly with our scheduled regular vaccines, and didn't seem to change safety and didn't seem to decrease immunogenicity of the scheduled childhood vaccines. So encouraged to give it at the same time. Here's trial 2. This is the one in kind of those early or late pretermers, I should say, about 1,500 kiddos. This is in a randomized, double-blind, placebo-controlled, multi-center in multiple countries. So the primary endpoint for this was medically attended RSV, lower respiratory tract infection. Secondary endpoint was hospitalization. They found a 70% efficacy in decreasing medically attended RSV, lower respiratory tract infection in this cohort, and about a 78-80% decrease in hospitalization. So those are pretty big, impressive numbers. And then this one was in 2016 to 2017. This was in 2019 to 2020, which is interesting because that was when we started to see COVID. This is our 35 weeks and up, so this is where really the majority of our kids that are getting hospitalized with severe or with RSV are seen. So same primary and secondary endpoint, 75% efficacy for decreasing medically attended lower respiratory RSV, and 62% for decreasing hospitalization. Mostly studied in those healthy term kids, less than 6 months. A few in the study had cystic fibrosis, or one in the study had cystic fibrosis, and a few did have Down syndrome. All right, so the other big update is the maternal bivalent RSV pre-fusion vaccine against the same epitope that nirsevimab is against. This offers polyclonal protection as opposed to the monoclonal protection of the passive immunoprophylaxis that we are offering the babies. So this was studied in women 49 and under, 24 weeks to 36 and 6. This was approved by the FDA in August to be given September through January, 32 to 36 weeks. Why did they approve 32 to 36 weeks when it was studied 24 weeks and up? There was a 5.7% rate of preterm births in the women receiving the vaccine and a 4.7% rate of preterm births in the placebo group. And they said morbidity and mortality increases less than 32 weeks. They didn't want to take a risk, so they just approved it 32 to 36 weeks. It's also approved for the elderly, but we're not talking about that. It's recommended by ACOG and the CDC. For the women that received this, there was some localized injection site pain, redness, swelling, and they did report more body aches than their placebo counterparts. But overall, no serious reactions. It's called Abrisvo, but I'm trying not to use trade names. So y'all know Synagis, Beyfortus is nirsevimab, and Abrisvo is the maternal RSV vaccine. So this was called the Matisse trial, double-blind, randomized, placebo-controlled over 18 countries over 4 RSV seasons. Pretty extensive. About 7,000 women and infants were monitored. Mostly term, late preterm infants. So you can see here on the left, their 2 primary endpoints were medically attended severe lower respiratory tract disease and just medically attended lower respiratory tract disease. Had some pretty impressive numbers to decrease severe disease. How they categorize severe disease is down here below. 80% at 3 months, which is really our, the highest of the high risk, and 70% all the way up to 6 months. So that's promising. And then still good, but a little bit lower, medically attended lower respiratory tract disease, around 50% efficacy there. I brought this out from the website since that was the entire cohort, and this is 32 to 36 weeks that extrapolated that data. At 3 months for medically attended, 35% efficacy, and 57% at 6 months. So definitely a little bit different numbers there. Still very good for decreasing severe disease. This is something to bear in mind when we're trying to determine who gets what, which, as we're coming to the end of RSV season, sorry I didn't get to you earlier, we'll see what plays out next year, how available nirsevimab is. There was a huge shortage this year. I'm sure some of you were able to give it out to some of your patients, but certainly not how we would have liked to. So first, before we get to this, just palivizumab versus nirsevimab, right? If you're eligible for palivizumab, you're also eligible for nirsevimab. If supply is adequate, everyone should get nirsevimab. It's a one-time injection for the entire season, as opposed to 5 monthly injections. If you start palivizumab and nirsevimab becomes available that season, you can give the nirsevimab and stop with the palivizumab. Of course, if you give nirsevimab, you do not have to give palivizumab on top of it. If a baby got palivizumab this year and nirsevimab is available next year, they can get nirsevimab. I think this will be more what we run into in the next year or so. This is the AAP flow diagram to help you decide if a patient is eligible for nirsevimab. So up top, are we in range? Are we in season or pre-season? Let's say yes. Are they less than 8 months of age today? Let's say yes. Did the mother of the patient receive the vaccine while pregnant? Let's say yes. Was the infant born within 14 days of receiving that vaccine? Let's say no, you're not eligible for nirsevimab. Mom needs to have 14 days to kind of allow for antibody production and antibody transfer, which tends to happen kind of at the end of pregnancy as well. That'll be important in a second. If you don't know maternal status, or if it was less than 14 days, then that child will probably be eligible for nirsevimab. So it'll be kind of interesting to see how documentation works for us. I understand asking this question recently. You're seeing a baby in clinic, are you allowed to go into mother's chart for this type of information? And the answer is yes, just document and only get the information that you need out of the mother's chart. That is my understanding. Somebody can correct me if they know differently. And this flow chart helps you with those high-risk second seasoners that might be eligible. All right, so let's just do a couple scenarios. So you have a 34-week-old baby that was born in October, had to stay in the NICU for a couple of weeks for an NG tube, is now ready to go home. Mom did not receive the vaccine. Is this patient eligible for nirsevimab? Yes, yes, correct. You have a term baby born in August to a mother who received the maternal vaccine 10 days ago prior to the birth, and it's now November. Is this baby eligible? Yes. They're a few months old, and they did not have adequate time for antibody transfer. Now you have a healthy 9-month-old baby going into RSV season. They didn't receive any immunoprophylaxis last year. Is this baby eligible? No. Only up to 8 months old is eligible. The rationale is that they probably have already had RSV. There's more chance than not that they have. Their risk for severe disease is greatest in the first 6 months and with that first infection. So that baby would not be eligible. There's some special circumstances to consider for nirsevimab. Cases where mom may be immunocompromised or may not produce antibodies, and she got the vaccine, that might be a baby that you're considering giving nirsevimab to. Of course, there's always going to be some case-by-case basis to look at. Placental issues that may affect antibody transfer. Like I said, antibodies really are most transferred at the end of pregnancy, kind of the last 4 weeks. You reach about like 50% transfer of the IgG1 at 34 weeks or so, and about 100% at 37 weeks. So even babies who are born like late preterm, depending on their situation, you may consider nirsevimab in those patients. Certain placental issues that affect antibody transfer. things that we might see here commonly-ish, low birth weight, HIV, those are things to think about. Any infants who got cardiopulmonary bypass or ECMO, that might wash out maternal antibodies. So even if mom received the vaccine, that definitely may be somebody to consider immunoprophylaxis in. And then infants that are severe disease that may otherwise not be qualifying. If that 9-month-old that we talked about did have something that made you wonder, that could be somebody to think about this in. I don't think this would be complete without talking about cost. Palivizumab costs about $1,000 to $2,000 for the 5-shot series. It looks like I saw that nirsevimab quoted by the CDC as this price for 5 doses, but I don't think that's correct. I think this is the price for a single dose. And then comparable, that's about $400. Sorry for anyone who's only listening and not looking. And then the maternal RSV vaccine is about $230. And these are the CDC prices. The free market price is just a little bit more. So definitely a significant difference between our new stuff and palivizumab. All right, so our takeaways. RSV is a significant burden on the medical system, has significant downstream effects for babies. Those at 6 months or younger are especially at risk for hospitalization and severe disease. We've got new prevention modalities in the maternal vaccine and nirsevimab, new immunoprophylaxis. Current recommendation is to either give the maternal vaccine or nirsevimab, but we kind of talked about some of those special circumstances. And then CDC and AAP have great guidelines, have frequently asked questions, and help you triage when nirsevimab is low, like this year. These are my references, and we have plenty of time for questions if there are any.
I do have one. So, palivizumab and and Bifordus, I cannot pronounce. Both are passive immunization
Yes.
in children.
Mm-hmm.
Is there any study on active immunization, like vaccines?
I didn't look into the trials I'm sure there are, here we go. Since there are, this P here is for pediatric, right? E for elderly and M for maternal. So we've got some in phase 2 here of live attenuated chimeric vaccine and protein based. So I didn't look into those, but they're out there.
But not phase 2 trials, not phase 2.
Just phase 2, yeah.
Much for the talk, Dr. Moran. I did have a question. For the palivizumab versus the nirsevimab, is there a big difference in efficacy? So is it better to get a kid on palivizumab if we can, or is nirsevimab more effective and should be the preferred aid for kids that are eligible for both?
So palivizumab, when I looked back at those studies, looked to be about 50% efficacious at decreasing hospitalization, I believe was their endpoint, as opposed to the 70% that we're seeing with the nirsevimab. So I think that's why nirsevimab is preferred and recommended. Of course, in times of triage, the CDC and AAP can help you decide who to give what to.
Thank you.
Sure.
Okay, so is there any data on how many women are getting vaccinated with the maternal or any are expected to get vaccinated with the maternal vaccine?
I don't have numbers, but I do know that there's lower supply of the maternal vaccine than they wanted for this year as well. I wish I could present you with numbers.
Okay.
Yes?
So one of the oldest medications that's been used for RSV is ribavirin.
Mm-hmm.
Is there any new updates about ribavirin using in patients with immunocompromised status? Or
I didn't look into that, but it is not recommended in use in RSV at this time. All righty. All right. Thank you all. Have a great day.